While acknowledging that the past traditions really were not quite correct, we also see that these early medical models were powerful in contributing to our modern biological tradition, and they continue to have a strong impact today. We now think of mental illness as resulting from physical illness and physical problems, or at least that these things can be related. And this goes back throughout our 1900s and really had a strong influence in the 1930s, where here biological treatment started to become our common everyday practice. And you saw things like insulin shock therapy, ECT, early brain surgeries, and that these biological models now began to ground how people saw psychological distress, as well as how they began to see potential treatments. And I'm going to show you two videos here. One is a video of early lobotomy, and I will warn you, it is a bit graphic and somewhat disturbing. And then I'm going to show you another video that is more of what modern lobotomy is like today. What you'll see is it's gone from being something that was incredibly brutal and incredibly damaging to individuals to something that causes very minor damage and can be very helpful for many people.
He was an idealistic doctor, hungry for fame, who would champion one of the century's most infamous medical procedures.
He wanted to solve the problems of psychiatry, and he wanted to do it fast.
The lesson here is not how a man can go off the rails, but it's how science can go off the rails.
Ellen Ionesco was the first patient to undergo a procedure Dr. Freeman had perfected only weeks before. He called it transorbital lobotomy.
In a transorbital lobotomy, Freeman would first have the patient rendered unconscious through the use of the electroconvulsive shock machine.
Just before he threw the switch, we all had a laying on of hands and went for a little ride.
Usually 3 successive convulsions are necessary, but in old people a single one may be sufficient, while in a sturdy young person 4 or even 6 convulsions may be administered without danger.
The patient would then enter unconsciousness for a relatively brief period, but several minutes.
Now that the convulsion has subsided, the nurse holds a towel over the nose and mouth of the patient.
Freeman would peel back each eyelid, insert his ice pick, and with a hammer, tap through the brain, wiggle it about, sever the frontal lobes, withdraw it. And when the patient came to, he or she would be given dark glasses to hide the black eyes they'd been given.
We didn't have a refrigerator, we had an ice box. The first ice picks came right out of our kitchen drawer, and they worked like a charm.
Turning now to the operation itself, very little preparation is necessary for transorbital lobotomy.
The instrument was put in above the eyeball and in the plane of the nose. You could feel it hit the roof of the orbit, and then with a tap of a hammer you could knock it through. The whole thing would take 3 or 4 minutes.
This patient came to the hospital this morning after breakfast, and he will leave tomorrow afternoon.
There are reports which he proudly writes down in his diary about fellow professionals fainting as he proceeds in this, or vomiting.
Dr. Watts didn't say anything. He simply turned around and walked out.
Spurred on by Freeman, the number of lobotomies performed annually soared from 150 in 1945 to over 5,000 in 1949. Despite the known side effects, there seemed to be an endless supply of willing patients. Ultimately, the fate of lobotomy would be settled by a pill. In 1954, a new drug called Thorazine began to sweep through state mental hospitals.
Thorazine was initially marketed as a chemical lobotomy. I mean, this was seen as a selling point, that it produced results similar to lobotomy, but without, of course, all the risks of the surgery.
Freeman decided to move to Los Altos, California, to resurrect his career. Far from the reproachful Eastern medical establishment, he could try to bring lobotomy to new categories of patients.
If housewives found their early 1950s existence too depressing for words, why, Freeman had a solution that would get them through their day happy as little clams. If children were misbehaving, conditions we might now see being called hyperactivity disorder, why they might need a lobotomy.
In all, Freeman lobotomized 19 children under the age of 18, including a 4-year-old. By 1967, Dr. Freeman had personally performed more than 2,900 lobotomies. In February, at Herrick Memorial Hospital in Berkeley, he performed his last when a patient died of a brain hemorrhage. Freeman was stripped of his hospital privileges and soon retired from his medical practice.
There's more about The Lobotomist at American Experience Online. Watch the full program on the web. A panel of experts answers your questions. Access additional interviews. And share your own views. All this and more at pbs.org.
Moving into the 1950s, what became incredibly important here was now we were seeing effective medications that could treat people with major psychological disorders. So the two categories of medications that came to rise here were major tranquilizers and antipsychotic medications. This was earth-shattering. This completely changed everything in mental health, because those individuals who could never be released from the hospitals because they were psychotic and they had psychosis for their entire course of life could now take a medication that allowed them to be released from hospitals. So this ended up changing the course of psychological treatment from the 1950s on, probably for the rest of our lives. In the 1960s, we saw another incredibly important movement called the Community Mental Health Movement. And here, the critical piece about this movement was individuals believing that communities could be better in serving the needs of those with mental illness than an institution could be. And it was important that this showed up in the 1960s for several reasons. One, if you recall, in the 50s, they discovered antipsychotic medications. So by the 60s, antipsychotic drugs were now widely available, which meant many individuals, if they kept taking their medication, would be able to leave institutions and have some form of a functioning life. In addition to that, President Kennedy was in office, and President Kennedy was very, very supportive and thoughtful when it comes to issues around mental health. And President Kennedy, with Congress, funded and established a nationwide community mental health center movement. So now across the country, there were many, many local community-based centers that could do things like check in with clients, monitor their mental health, monitor their medicine compliance, but allow them to live independently or in smaller areas with other people who could help them. Many wonder, why was it that President Kennedy was such a fan or such an advocate for those with mental illness? And some people know that he had a sister, Rosemary Kennedy, who suffered from mental illness, but people don't often know what really happened. And this is, again, one of those spaces where psychology interfaces with our politics of the day and with our social beliefs of the day. And so Rosemary Kennedy, not unlike those women who were unruly and were accused of being witches, Rosemary Kennedy was lobotomized for moodiness. The story being that as a teenager, she was at boarding school and she kept sneaking out at night to go see boys. And when her father found this out, he went to have her lobotomized to control her behavior. So one of the things you will often hear me say is psychology is inherently political. And this is a perfect example of the ways in which social norms and beliefs of the day were enacted through the field of psychology with great influence. The community mental health movement and the fact that there were antipsychotic medications led to a significant portion of those who had been in institutions now being released and sent to community centers and sent to live independently. And so the population of those that were institutionalized indefinitely decreased by over 420,000. So roughly 550,000 people had been in institutions and were likely to live out their lives in institutions in the 1950s. But by 1985, it was down to less than 130,000 people. Now, there are people who are concerned that the deinstitutionalization movement actually ended up going too far, and that now it can be very difficult to find a bed for somebody who needs intensive psychiatric care. And because of insurance companies, even if you find a bed, there's often limitations on how long someone can be there and what kind of treatment they can receive. Another one of the major theories or major perspectives that changed the field of psychology was psychoanalytic theory. And this was related to some of the early moral therapy models. In fact, Freud went to a presentation by Charcot and watched the performance of hypnosis in order to treat what they called hysteria. So hysteria was generally if you had a psychological symptom that was driving a physical challenge in the body. So someone who there's nothing wrong with their eyes, but for some reason they are experiencing blindness or they're experiencing paralysis, and there's no biological cause for the symptom. Freud came to believe that it was actually intrapsychic forces that were embedded in an individual's subconscious that was the cause for the dysfunction. They were having some subconscious conflict that they could not deal with, and they had to block those emotions because it was too terrible to think about. And in blocking those emotions, that energy got transferred into a physical manifestation of disease. In order to then treat them, it wouldn't make sense to just treat the paralysis or treat the blindness. You have to treat that underlying blocked emotion. And if you discharge those blocked emotions, they would spontaneously heal, and then those physical functioning challenges would now be back to normal. And this is where we get this term catharsis, that discharging of blocked emotions is cathartic or is catharsis. When we have that moment where we've been able to unleash blocked emotions, we feel better. And this was in essence the underpinning of psychoanalytic theory and led to our more modern psychodynamic theory. And the fourth major perspective in psychology is the sociocultural perspective. And this moves away from the idea of the person being the dysfunction and instead says that society is actually failing the person. When society fails individuals, they experience symptoms that then society will label as abnormal behavior. They assert that if we really want to understand problematic behaviors, we have to go back a step and look at what are the societal ills that led to the problematic behavior. And they would say things like poverty, abuse, discrimination, marginalization, and all of the isms, racism, classism, sexism, heterosexism. These things existing in society result in individuals manifesting symptoms that then we will label as being mental illness, but they really are problems in living with a society that is dysfunctional. And that by labeling that individual as being the cause of dysfunction and not looking at society, we are then harming individuals, stigmatizing them, and then reifying our beliefs about abnormality. And so when we reify, we take something that's not true, but because we believe it's true, we create conditions that make it appear to be true anyway. So we're pathologizing the people who are highlighting that there are social injustices that are harming people, pathologizing those that are threatening the status quo. And so the sociocultural perspective argued to get rid of all labels and get rid of all diagnosis because we are just stigmatizing those who are already harmed by society. Instead, we need to focus on how society creates illness in individuals. And this is a really important argument and thing to think about. And the debate about diagnosis still rages on today. There is a lot of value in the sociocultural perspective, but many will still argue that not offering diagnosis actually goes too far, because when we don't diagnose, we are actually leading to individuals suffering without understanding of why, and it's going to take a long time to change society. While we're waiting for society to change, we still have to engage in diagnosis and treatment of individuals. And as we go through the semester, I'll encourage you to come back to these arguments, see how your opinion about them stays the same or changes across the course of the semester. And finally, we arrive at the biopsychosocial perspective. This is the perspective that dominates the field right now. And it's proposing more of an interactionist model, that abnormal behavior is way too complex for any of these simple models, or for most of the perspectives that are offering some explanation but then fail to explain other pieces. So instead, the biopsychosocial perspective says we have to think about all of these factors at once. We have to think about biology. We have to think about underlying psychological and subconscious processes. And we have to think about sociocultural factors if we want to understand what's happening in a given person's life and in their experience of symptoms right now. And one of the ways in which we study this, which we'll be talking about in future lectures, is the field of behavioral genetics. What they're doing in that field is they're looking at the underlying biology and genetics while looking at the environment, and ideally also looking at sociocultural factors, and then putting all of those things into a model that helps us to better understand psychological disorders and psychological distress.